Well, welcome to today's webinar entitled Help Them Quit, Tobacco Cessation Interventions for TB Patients, sponsored by the Southeastern National TB Center. This is Karen Simpson, Co-Executive Director at the SNTC, and I'm moderating today's webinar. Our speaker is Kathy Cook. Kathy is a licensed clinical social worker and a certified tobacco treatment specialist. She's currently the lead systems change coordinator for Swanee River Area Health Education Center in Florida. She began her social work career in child welfare and then moved to the hospital setting, where she ultimately served as the director of the Department of Patient and Family Resources from 1997 to 2011. Her experience includes individual counseling, management, clinical supervision, project management, and multidisciplinary team leadership. Her recognitions include National Award for Excellence in Perinatal Social Work, Gainesville Social Worker of the Year, and Florida Social Work Healthcare Leader of the Year. At Swanee River AHEC, she has worked with regional health and dental clinics, a homeless clinic, and community hospitals to ensure best practices with tobacco using patients, including referrals and maintenance of tobacco cessation. Today, Kathy will provide information for treating tobacco use and dependence, including counseling tips and techniques. We welcome you, Kathy. I'll turn it over to you now.
Karen, I suppose the only thing I might add to my bio would be that at this point in my life, in my career, and in my life, my passion is tobacco treatment. So I'm excited to be able to be here today and to talk to all of you. And I can see that many of you are nurses and that some of you are physicians, but it helps me if I know kind of what your background is. And I'm seeing here that it looks like we have primarily nurses. Is that right, Ellen?
Yeah.
I have a nurse.
About 70%.
Okay, I have a nurse on staff to help me with technical medical kinds of issues. The nurse right here. Ellen, is your name on the presentation? Okay. So welcome, nurses. And all other healthcare professionals. I'll talk to you a little bit about our objectives before we get started. We're going to talk about the key guidelines that come from the 2008 clinical practice guidelines. We'll show you a picture of that guideline in a moment, but we're going to talk about some of the recommendations from that guideline for treating tobacco use. We're going to describe major components of brief intervention because I know many of you with your busy schedules really don't have time to do more intensive treatment. But if you do, we'll touch on that as well. We'll talk about interventions for three different kinds of patients. Patients who are willing to quit, patients who are not willing to quit, and those who have already quit, are making a quit attempt. And then, as I said, we'll talk a little bit about intensive treatments. The impetus for this presentation is the fact that recently there has been some research and data that support an interface between tobacco use and tuberculosis. There are more than 1 billion tobacco users in the world, and tobacco use kills just about half of its users when used as directed. 80% of those tobacco users are currently living in low and middle income countries, and really that's no accident. They're targeted by marketing as tobacco treatment becomes more effective and people in the developed world begin to quit. The tobacco companies know where their market is. And I understand that there are 2 billion people who are infected with the TB, with the tuberculosis bacilli. This is also a disease of poverty, and the vast majority of the deaths occur in low and middle income countries, the same as tobacco use. I won't spend a lot of time on this because I believe that your first webinar set up the association between tobacco use and tuberculosis and gave you some of these same data. But there's a clear link that TB patients who also smoke, they're more likely to have a cough. And it's a different kind of a cough from a tuberculous cough. The kind of cough that smokers have is usually due to the fact that the cilia, the organelles inside the respiratory system, that sometimes they're referred to as the mucociliary elevator, that when a person smokes, those are paralyzed for just about 30 minutes. So if someone is smoking all day long, those are paralyzed a lot of the day. But when they don't smoke during the night, 4 hours, 6 hours, 8 hours, and wake up in the morning, there's a terrible cough, really, when the cilia have awakened themselves, trying to get all of that gunk out of the lungs. Smokers are more likely to have pulmonary tuberculosis. They may have those cavitary lesions that you saw in the last photo, which was, I believe, a facsimile of a pulmonary cavitation that a TB patient may have. And they're more likely to be sputum positive. And TB patients who smoke are much more likely to spread TB than non-smokers. And one of the reasons is that different kind of cough. Tobacco weakens the immune system. I understand that TB patients are already suffering from a weakened immune system, and we know that tobacco use slows wound healing, increasing the risk for diabetes, and all of those are related. And we also know from the data that tobacco users are more likely to use alcohol. Very recently at a tobacco conference, I heard a researcher who let us know that, in her opinion, that we in tobacco treatment should be more aggressive in treating and working with our patients who use and abuse alcohol. Those are comorbidities, codependencies. And there's an increased risk for respiratory diseases, of course, with tobacco users. Emphysema, chronic bronchitis, bronchiolitis, and eventually those symptoms end up giving the tobacco user a diagnosis of COPD, for which there is no treatment. But what we want to do for our tobacco users is make their diseases easier to live with. And hopefully for your patients who have TB, we want them to be able to recover from TB in a more efficient and timely manner. Why is a TB program so special? I think one of the reasons is that you have regular contact with your patients and you can provide services over a period of months. And that makes a really big difference. Not many practices actually have that opportunity. Patients who see a primary care physician may see them once a year or may see them every 6 months, but that intensive kind of contact, it really makes a difference with tobacco users. And it involves patients who are going to be motivated. They're motivated by their obvious illness. They're coming to see you in the tuberculosis program because they're sick. And sick is usually a pretty good motivator. And I also understand from the SNTC that you involve families. Not only is the support of the staff in your centers important, but the support of families for patients to quit tobacco is so important. So here's our first objective that comes from the guidelines mentioned in the Treating Tobacco Use and Dependence, the 2008 update for providers, or encouraging all providers to provide tobacco cessation. And here it is. Here's the book. In tobacco treatment, we sometimes refer to this as our Bible. The clinical practice guidelines were first developed in 1996, and they were updated in the year 2000, and then they were updated again in 2008. Clinical practice guidelines over the past 20 years have become important in many facets of healthcare, and those in tobacco treatment, physicians and nurses and researchers and other healthcare professionals began to realize that they needed some sort of guidance. And so these were developed and revised again. The most recent one was 2008, as I mentioned, And the panel of experts who put these together from the most current research and meta-analyses was a physician named Michael Fiore at the University of Wisconsin. Unfortunately, though, recently he has let us know that there's unlikely to be an update to these particular guidelines anytime soon, due primarily to the high cost of putting together such a guideline. But those of us in the tobacco treatment field, we look at the current research. We rely a lot on the CDC and information that comes from the CDC and the Public Health Service, as this did. And the 2014 Surgeon General's report, the 50-year annual report, has also been very useful. What happened in 2008 that really drove the development of these guidelines were three things. It became obvious that tobacco use is a highly significant health threat. I mean, that does sound obvious to us now, but 50 years ago in America, almost 50% of the men were using tobacco. And now that number for the total population is 15 or a little bit less than 15%, depending on how recent the statistics are. It varies amazingly widely from state to state. I don't know what states everyone here is from, but in California, the tobacco use is less than 10%, 9.1, I believe, the last time I looked. And in states like Kentucky and West Virginia, it's right around 25%, with Arkansas and Mississippi not very far behind. So it's really interesting, the spread of tobacco use around the country. So another thing that happened was we began to figure out really good ways to treat tobacco users. And we learned that if we deliver treatment in a timely and effective manner, that it's going to reduce the risk of the tobacco users suffering from a smoking-related disease. Now, make no mistake, tobacco use is a chronic addicting disease. It's what we learned from the 2014 Surgeon General's report. In fact, that called it the most undertreated chronic disease in America. It's a chronic, relapsing, addicting disease. But what the final thing that drove the development of these guidelines for Dr. Fiore and his panel of experts was noticing that there was a disinclination, he called it, among clinicians to intervene consistently with tobacco users. In the guidelines, he actually refers to it as neglect. And I'll give you some numbers about that in a moment. So the overarching outline in the 2008 guidelines includes 10 key recommendations, and I'll just go over these right now and then go into them in more detail as we move through the presentation. As I said, it's a chronic disease and often requires repeated intervention and multiple attempts to quit. Tobacco users are often surprised when we tell them that on average, it takes a person 10 quit attempts to be successful. And I know that professionals, that also can be very discouraging. And there are effective treatments that can increase the rates of long-term abstinence. We'll talk about those. Identification and documentation, those are really key. Electronic medical records has helped us a lot in making progress on those issues. But it is absolutely essential, the identification. Tobacco dependence treatments are effective across a broad range of populations. In the 2008 clinical practice guidelines, sometimes we call them the CPG, they did their research and their analyses on a wide variety of populations. Of course, men, women, pregnant women, people with low socioeconomic status, HIV patients, and adolescents. So tobacco treatment, we know, works across a very diverse population, as well as the LGBT population. Don't want to leave that out. Clinicians should encourage every patient willing to make a quit attempt. And brief treatment is possible. We know that people in busy practices don't have a lot of time, and we think you can do this, the brief treatment, in less than 3 minutes. Intensive treatments are better, but always say something. Counseling is very effective, and when you add medications to counseling, it doubles the chances of success. We'd really like for physicians to understand the medications and that they're effective, and to encourage use. And physicians and nurses, it's also really important to know that one thing we talk about a lot is combination therapy. It's a combination of counseling and medication. Counseling and medication together have the best success rate. And in a moment, I'll talk to you a little bit about even combining medications, although I believe as part of this series in the next few weeks, we're going to do a webinar that is specific to medication. So I won't spend a lot on that today. And telephone quit lines. Every state in the country now has a telephone quit line. If you call 1-800-QUIT-NOW, that will take you to a telephone quit line in your state. If you don't have a quit line, it may go to a national number, but every state at least has access to a quit line. In Florida, we have a pretty robust in-person or face-to-face option that tobacco users can choose, and it's all free. And they very often provide free products as well. And we don't want to forget tobacco users who are unwilling to make a quit attempt. It's easy to give up on patients who are resistant and say they're not going to do it, they don't need help. But we'll talk about some ways you can have a brief conversation that might be effective in increasing future quit attempts. We know our treatments are clinically effective, and that relative to other interventions for things like hyperlipidemia and hypertension, that they are just as effective. I know it doesn't feel that way sometimes, but they are. So, do our patients want to quit? What do we know about that? In 2008, we knew that 70% of smokers see a physician every year. And of those who see a physician, if you get down to the end and are told they need to quit, 44% of them will try to make a quit attempt. My favorite piece of information on this slide, though, is that 70% of smokers report wanting to quit. That was 2008. I think it's a little higher than that now, and I'm an optimist. So I like to believe that there's a quitter in everybody somewhere. And we know that even smokers who relapse, that they want to try a quit attempt again within 30 days. And this last bullet in the light green is really key, not only to physicians, but to people who work with physicians. Because in America, there still is quite a bit of respect and even perhaps deference to physicians, especially among tobacco users who are concentrated, as we know, in the low socioeconomic strata of our society. So I cannot tell you how many patients have said to me that I'm in class because my doctor told me to quit. My doctor told me it's bad for me. So if your physician's listening, say it to your patients, say it every time. If you're nurses or other healthcare professionals who see doctors, let them know. It makes a difference. Say it, and say it every time. I know some practitioners, my own PCP, in fact, is a little bit resigned, says, people quit when they're ready. Well, I don't argue with that, but what I do think is we can help them get ready. And here's some interventions. But it's a really interesting fact that only 25% of medication patients reported getting any practical assistance with quitting or ensuring follow-up of their progress. And one reason that that's so interesting is that of the money that we spend in America on tobacco treatment, on treating patients who are sick because of tobacco, that's about $3,000 a year. Most of it is spent in the Medicaid program. So those are the patients we really need to be talking to. And this was a little bit shocking to me that 1/3 of adolescents who visited either a physician or a dentist, they got no counseling about the dangers of tobacco. And that's an easy thing to do, especially if you're not smelling tobacco, you have a young adolescent who hasn't tried tobacco. It's really pretty easy to put a word in there for that. And there's so many teenage programs, we call ours SWAT, Students Working Against Tobacco, around the country, and they're just great programs to involve kids in, keep them busy, keep them doing something, and keep them tobacco free. And pregnant women, since this is 2017, I like to think that that's a better number. Of the 81% who were identified at physician visits, only 23% of them received counseling. This is pregnant women. And I'll talk a little bit later about judgment and not being judgmental, but the hardest situation I found to withhold judgment in is seeing a pregnant woman who uses tobacco. So we owe it to the pregnant woman, to the developing fetus, to say something. So I don't know if you all can see the question or if you have answered that yet, but I suspect it's the great majority. Oh, for a minute I saw 100%. I know it's close, though, that you do offer practical counseling, or you might not be listening to this webinar. Hopefully you'll be able to convince your colleagues that it's an important issue as well. But it's looking really high.
Almost 80%, 78%.
Almost 80% of you are helping your patients with practical assistance. All right, thank you. I knew this was going to be a good group. So now we'll talk about the 5 components of a brief intervention, because brief is always better than nothing. Don't do nothing. If you can just say a couple of sentences, do it, but don't do nothing. Always remember to mention tobacco use. And from the 2008 CPGs, from those guidelines, we've come up with the 5 A's. And I do know that some family practice offices and some physicians around the country really use this in a robust kind of a manner, the 5 A's. The first one is the ask, or the identification. Identification is interesting. Identification alone is not shown to make any difference in terms of quit attempts, but identification that increases the clinician intervention is proven to make a difference in the number of quit attempts that a patient attempts. And it also guides the identification. The ask will guide the appropriate interventions, because once you ask a patient, they will often start to talk about it. I often think that, I know you're certainly not an emergency service, but patients who show up in emergency rooms for some sort of exacerbation, say of COPD, and I don't know how often a patient with tuberculosis might show up in an emergency room, but in emergency rooms they're always going to ask them, but they're so busy that once the patient says yes, even if the patient says, yes, I know I need to quit, they just keep going. And that is so often the answer you'll hear when you just ask the question, yes, I smoke, but I know I need to quit. That is a golden moment, and nobody knows teachable moments better than nurses. So I would ask you to hold on to that, yes, but I know I need to quit. Take a breath when you hear a patient say that. That might be your moment. And in your busy schedule and in the patient's moving from one place to another, that might be your only moment. So take advantage of it. So the 5 A's are ask, advise, assist, assist, and arrange. And we'll go through those. And some people have shortened it, and that's okay. However, you can remember it to 2 A's and an R. That's ask, advise, and refer, which encompasses the assist and arrange. And here's an algorithm, if this is helpful, for thinking about where you go with a patient in terms of his or her tobacco use. If they use tobacco, are they willing to quit? Or are they willing to try a quit attempt? Then you can provide some treatment and promote motivation. Motivation is a lot of what we'll talk about during this presentation, is tapping into that person's own internal motivation. And if they want to use tobacco, you want to know a little bit more about that, because relapse prevention is key. I think I said 10 times takes the patient to quit. And then encourage them and support them in their quit attempt. So here are the 5 A's model with a little bit more detail. Ask, we've talked about that a lot. Identify and document. I honestly think that we've made so much progress on that, especially with the electronic medical record, that when a patient tells me in a hospital or a clinic they didn't get asked, I just think it's an oversight. And hopefully eventually we'll have electronic medical records that won't let us move past the prompt of asking the tobacco user about tobacco use. And some of you may already have that. Advice to quit: clear, strong, and personalized. We'll talk about general versus personalized information in a moment. Assess the patient's willingness to quit. Sometimes that's referred to as stages of change, and there are many stages of change, maybe 5. But really the simplest way to think of it is, are they willing, are they unwilling, have they already quit? Because regardless of the nuances, you can tap into that motivation wherever they are. And assisting with a quit attempt, that's very often medications. I can't say enough about appropriate use of the medications. Maybe I'll take just this moment to at least list them, the 7 first-line medications. There are the 3 over-the-counter nicotine replacement products, the patch, the gum, and the lozenge. They're expensive if you buy them over-the-counter, but many insurance plans are now covering them, and they're all covering them in different ways. Since the Affordable Care Act, as of January 2014, said they could no longer be denied. So you can imagine insurance companies have come up with very creative ways not to deny them. So ask the patient, look at your insurance, call your provider, or call your insurance case manager, because all of the Medicaid managed care products or the Medicaid replacement products will offer it in a very different way. But medications are terrific. That's the first 3. The patch, the gum, and the lozenge. The other nicotine replacement products are the nasal spray, which isn't used often, but sometimes in institutional settings, and the puffer, which is badly named. It's a great product, but it's unlikely to ever be over the counter. The nasal spray and the puffer are prescription drugs, and they're expensive. They do have to have a prescription. If insurance covers them, wonderful. Remember, it's a good product. One reason it's a good product is because it's shaped a little bit like a cigarette. It's kind of a long tubular thing, the puffer, although they just take a little bit of the nicotine in, and it soaks in through the membranes. It isn't actually inhaled into the lungs. So it's a really good product for some people who may be able to pay for it. And then there are the non-nicotine replacement products, which I'm sure you've all heard of. The bupropion, also known as Wellbutrin or Zyban. And then there's the varenicline, which is Chantix. And just so you know, Chantix has been, the black box warning has been taken off of Chantix. It's a very good drug, Chantix is. It's not for everyone, but it works. It interrupts the the receptors. And the last is arranging follow-up. We'll talk a lot about that as we go on because follow-up is absolutely key in a successful quit attempt. And the window for relapse is very short once a patient quits. So if you're seeing patients weekly, that's a wonderful thing. Or if you have someone in your office who could make a phone call, that's a wonderful thing. If you're making follow-up phone calls anyway, add that in there. How's your tobacco quit attempt going? So now we're going to talk about the patient who's willing to quit, the patient who's recently quit, and what we want to do is to help you talk to different kinds of patients in slightly different ways. So advice. We talked about advice. It should be clear. If a physician says it's important that you quit smoking right now and I can help you, they may very well take that away with them. Cutting down while you're ill is not enough. Occasional or light smoking is still dangerous. And those are all true, and they are straight out of the practice guidelines. A word I would like to say about cutting back, though, is that cutting back is very dangerous because it maintains the addiction. And anytime a stressful event happens, a patient is likely to go right back up to the previous level of smoking, or even less than the previous level, but still a half a pack a day is dangerous. Nonetheless, if a patient tells you that they're going to cut back, that should tell you something about that patient's motivation. They are wanting to quit. So that's something that you can use, and it's a positive sign. I wouldn't just shut people down when they say I'm cutting down and say, well, that's not enough. If they're cutting down, you need to tap into that motivation, and we're going to talk about how to do that. The advice should be strong. As your clinician, your healthcare provider, your nurse, your respiratory therapist. I've talked to a lot of respiratory therapists in hospitals who've taken on the role of being the tobacco treatment specialist and are often very passionate. I need you to know that quitting smoking is the most important thing you can do to protect your health. And then offer help. The staff and I will help. Then we're going to talk about how to personalize it. And those of you in a TB clinic, same as here at the SNTC, do have an advantage, believe it or not. It's sad that your patients have tuberculosis, but it makes it easier for you to talk about their tobacco use. Talk about general advice versus personalized advice. Instead of saying smoking is very harmful for your health, I'm pretty sure everyone knows that now. Maybe in 96 and 2000 and 2008, they didn't know it like they do now, but I can tell you that the homeless clients at the homeless clinic where I work, they all know it's bad for you. But what you can say is if you quit tobacco, you'll recover better from your TB. It's important for you to quit smoking as soon as possible. What you can say is as soon as you quit, your coughing and your sputum will decrease and your breathing will become easier. You can use your expertise in tuberculosis with your patients who are sick to help motivate them. Harmful to breathe the smoke from other people's cigarettes or cigars. Now, I suspect that the majority of your TB patients are living with another person. And if they're using tobacco, it's dangerous for the other person. And what you can say is by smoking in your home, you're putting your children and your family at greater risk of TB. Now that sounds really serious and scary to me, but you do have that advantage of being able to talk about that. One of the best things you can do to improve your health and your family's health is to not allow any smoking inside your home. Well, that is absolutely good advice, and that's the way we do it. But how about this? Reducing your risk of getting TB again. Now that may get your patient's attention. So you want to know where your patients are, what stage of change they're in. But very simply, you just want to know right now how they feel about quitting today. And you're seeing them in one moment of time. So that's all you're getting when you ask them that question, is how they feel about quitting today. Sometimes I even ask the question that way. Instead of asking a closed-ended question like, are you willing to give it a try, I might say, how are you feeling about quitting tobacco today? And if they say yes, then I can assist you. Let's talk about medication. Let's talk about some medication that would help you. Or let's talk about the best way for you to quit. And if you're a member of a special population, I can give you some additional information. The CDC website is terrific, and your own tobacco control programs in your own state, I feel sure they have lots of downloadable PDFs in the same way that the CDC does, or maybe they'll mail you brochures. Or I know here in Florida, if physicians' offices or clinics call us and want information, we'll either mail it or we'll take it. We'll take it to the office and we'll talk to the office staff about what's the best way to use it. We'll give them posters to put up. So I'm pretty sure in every state there's some level of that assistance that's available that you can provide to special populations, whether it's pregnant women, members of the LGBT community, whether it's homeless people, whatever it is. I'm pretty sure that you can access that information. And if a patient says no, then we're going to provide an intervention that may help increase future quit attempts. Counseling and medication, as we already said, together, each of them enhances the other one immeasurably, really. Well, what we tell people about medication is it doubles your chance of a successful quit attempt. So again, you want to recommend medication, take a few moments, give the patient some practical counseling. And practical counseling is as simple as problem solving and coping skills. And that's really the way the Joint Commission looks at it too. That's what the Joint Commission wants hospitals who choose the tobacco measure. That's what they want them to do. They want them to talk about problem solving, which is just as simple as asking the patient, what's going to be the hardest thing for you about quitting? And how do you think you're going to overcome that? How can I help you? How are you going to cope with that? So there you have it. That's practical counseling. That's day-to-day living kind of counseling. And you can do that in your home. You may be talking to patients about stresses in their lives anyway, so it'd be really easy to fit the tobacco treatment in because most people use tobacco to cope with stress. Intra-treatment support, that just means treating the patient, and the guidelines strongly encourage that, treating the patient for tobacco use in the context of the visit to your clinic. And then the supplementary materials, we talked about that. Make sure you've got some. Put some posters on the wall. Put some out in your waiting room. Put them where people can see them. Or put them in the drawers where the clinicians can hand them out. Here's a little acronym also to help you remember the assist part. It's STAR, S-T-A-R, for a patient who's willing to quit. I can help you with the little STAR acronym. Set a quit date. If you don't set a quit date, you're not going to quit. That's actually true, and the guidelines strongly encourage setting a quit date. On the other hand, recently, there's been a little bit of controversy about pressure to set a quit date really perhaps alienating some patients a bit. My personal experience in the homeless clinic with people who have a hard time setting a quit attempt is either that they don't quit, and they keep coming back, but they don't quit, or they may come in and say, all right, I'm going to quit tomorrow. And then I ask them about their quit date later, and they say, I don't know, I quit a few weeks ago, but I'm still quit. So they say, I'm going to quit tomorrow. I say, all right, I have some patches for you, and I have some gum for you, and let's talk about it. Let's talk about tomorrow morning. How's tomorrow morning going to go for you? There are some people who just can't say, well, on my birthday, I'm going to quit, and when the birthday comes, really do it. But some people can do it and are good at it. Just spend a little time exploring that with your patient. Can you think of a day that would be good for you to quit? A day that's important to you? I mean, I've had people tell me it was the day my mother died of lung cancer. And then I have other people who choose religious holidays, Christmas, Easter, whatever it is that works for that person. And tell people, that's the T in STAR, is tell people. Tell your friends, tell your family, tell everybody around you, because they could be some of your biggest triggers or your biggest danger signs is the other people in your life. And most people who care about a tobacco user, even if they use tobacco themselves, they're going to try to help them. They just are. They're not going to try to make their lives more difficult, and certainly not people in your healthcare system. Anticipate the challenges. We talked about that. Look at problems. Take tobacco products from your environment. That can be a really tough one. Sometimes I'll start with something as simple as, what do you think about taking the tobacco out of your car? Getting your car cleaned and starting there. Get your car detailed, see what happens. Arranging follow-up. Follow-up is really key because relapse is so common. You can do follow-up by phone or in person. Really important within the first week of the quit date, though. If you're discharging a patient from your clinic, if you're not going to see them for a month or so, refer them to a program, give them the number of the telephone quit line in your state, 1-800-QUIT-NOW. That will always get you from wherever you are to a quit line. You want to identify problems that have already occurred. What happened the last time you relapsed? And if tobacco use has occurred, review the circumstances and get the patient to recommit to abstinence. But right here I want to say a word about relapse and the difference between relapse and a slip. Or in the guidelines they call it a lapse and a relapse. A lapse is maybe 1 or 2 cigarettes, a bad moment. And what we tell people in our clinic is if you have a slip and you're wearing the patch, don't take it off. It's just a slip. Because if you take it off, what's going to happen? Yeah, you're going to go right back to the pack-a-day or whatever you were, to the poisonous, to the dirty nicotine versus what we call the clean nicotine. Now, a relapse is something different. A relapse is just giving up altogether and going back to your former level of tobacco use. And people talk to me about not wanting to quit again because of the failure. And what I would say is, let's reframe that. Let's not call it failure. We could call it relapse, or my favorite thing lately is let's call it practice. Takes people 10 times to quit, so you had a successful quit attempt for however long it was, so you are more likely to be successful on your next quit attempt. Every time you have a relapse, that's practice. You'll be better at it next time, like anything else. You know, pick yourself up, dust yourself off, get back on the horse, and get on your journey again. Now we have patients that are a little more difficult, who the day you're talking to them are not willing to quit. Now the guidelines from 2008 say it's because they lack information, but I think, like I said earlier, not many people don't know that tobacco is harmful. Maybe there's some specific things they don't know. Sometimes it gets people's attention if you tell them about the mucociliary elevator and those cilia being paralyzed. That sometimes gives people a visual, I think, that may get their attention. But tobacco is going to cause lung cancer or all different kinds of cancer. That may not get their attention. But again, there's lots of literature that you can give people, tell them, put it in a drawer, hold on to it. You know, maybe one day you will feel like looking at it. But the lack of information about the benefits, now I think that's real, and that does get people's attention. I'll show you a chart in a moment. Right, we inserted that PDF. So I'll show you that in just a moment, a downloadable PDF, I believe. People certainly may lack the required financial resources. Here in Florida, a box of patches, gum, lozenges cost you about $40 or $50, and that's a lot. So that's when you can refer people to the quit line or to their insurance company. And that actually is a tough one, because the research now is saying that people need a lot longer than 2 weeks or 4 weeks or 6 weeks to quit. and our job is to help people and be resourceful ourselves. A lot of people have fears and concerns about quitting, and what you want to do is tap into what those are. That fear of failure, that's a big one. Some people just plain enjoy it. And again, there's the demoralization because they've relapsed before. So here are the benefits of quitting. And we get that from our quit line from our Tobacco-Free Florida. I'm sure you can get something similar, maybe from the American Lung Association or the National Cancer Society. Lots of places have posters just like this, but it gets people's attention. In 20 minutes, the blood pressure goes down, the heart rate returns to normal, and in 8 hours, the carbon monoxide level in the blood drops to normal. The oxygen level goes back to where it's supposed to be, and people are interested in having enough oxygen. They really are. When you use a CO monitor, it's really fascinating how well it gets people's attention. Some people don't want to do it because they're afraid it's going to look really, really bad, but most people are happy to do it. And they're interested in these other things too, about the nerve endings and about the medical issues disappearing. 10 years, life expectancy is comparable to that of a non-smoker. Now, the risk of lung cancer, that never goes away completely, but it decreases by 50%, so that's something. Now, if you don't have a CO monitor in your office, I would encourage you to look into it. They're kind of expensive, but I think that the return on investment is really pretty good in terms of how well it gets the patient's attention. What it does is it mimics a test that respiratory therapists do with an arterial blood gas. I think it's called a carboxyhemoglobin. And so they found that the scores were so similar that it would be a good tool to use in the field when you're not going to do an arterial blood gas. So anything below a 7 on a monitor is a non-smoker. And when people come into our classes, our treatment groups, they'll blow 20s or 40s or 60s. I've even seen something as high as a 94. But if they're there for an hour and a half or 2 hours, by the time they leave, it's going to be 10 points lower. And that really gets their attention. So it's a wonderful tool to use, especially with patients who are not willing to quit right now. So we're going to keep talking about motivational interviewing and using that to our best advantage with clients. Motivational interviewing was developed sometime in the early 70s by a couple of psychologists named Rolnick and Miller. I don't think it was exactly brand new, but they repackaged it and called it motivational interviewing. There's a great book that you can Google or find on Amazon called Motivational Interviewing in Healthcare that walks you right through the process. But it's directive, it's patient-centered, it elicits patients' behavior change by exploring their ambivalence. When I talk about motivational interviewing, when I do presentations on motivational interviewing alone, at the beginning of the class with professionals, I'll have them think about a behavior they themselves want to change. You want to eat better or you want to exercise more. And then at the end of the class, I have them work with a partner and use some of the tips and techniques they've learned. So it works with any behavior is my point. It's especially good with tobacco, and that's where we use it the most. It'll help you work with a patient to resolve some of that ambivalence and minimize resistance. I want to quit, but I don't. I want to quit, but I don't think I can. And really it involves empathic listening. If you look at this fella here, I think he's supposed to be a physician, but if you just look at the way that he's leaning forward a little bit, he's close to his patient, he's making eye contact, I mean, that's empathic listening. And the interesting thing about empathy is that even if you've never smoked before, you can still do it. And patients know. Patients know in that moment when you're doing what he's doing, if all of your knowledge and skills are not sitting between you and the patient, that you're just there in that brief moment. I don't care if it's 30 seconds. Patients know and they feel it, and it makes a difference. So we talked about this, exploring their feelings, eliciting support, and change talk. What change talk is, it's that, I know I need to quit. When you hear that, that's that teachable moment. That's when you want to get a hold of it. And you want to have them use their own words. It's a lot more effective than clinician lectures for argument or quitting. What I'd ask you to take just a minute to do right now is to think about the last time that you had some kind of argument or disagreement with a family member or a friend, anybody, but you felt strongly about it. Think about what you remember. I know what I remember, and that is I told him I do not want to go to Idaho on vacation. I have never wanted to go to Idaho. I want to go to Italy. That's pretty much all I remember. And I don't even remember what his arguments were for wanting to go to Idaho, but I remember I let him know. So the point here is that patients remember what they say, not what you say. Back again to that exception. If you're the doctor, you give them one clear sentence, they might remember that. But in general, what they remember is what they say. Like if you ask them why they want to quit. So I can climb up the stairs to my apartment. Now they're going to hold on to that. Or so I can go to my daughter's graduation. Yeah. So empathy, discrepancy, rolling with resistance. We'll talk about that, rolling with resistance when patients do argue with you. You need them to stop. You really don't want to get your patients arguing for why they should quit tobacco. No, that's what you do want them arguing for, excuse me. You don't want them arguing for why they're going to continue to smoke because their grandmother smoked to be 100 and never had any problems. When you hear that, you're pretty much going to need to stop. So, in terms of expressing empathy, it's done really well with an open-ended question. And I know that you all know what an open-ended question is, but I'm here to tell you, I teach this stuff, and it's harder than you think. We have this exercise when we turn open-ended questions, closed-ended questions into open-ended questions, like when did you have your last cigarette? Turning that into an open-ended question is, tell me about your tobacco use today, or tell me about your tobacco use yesterday. But it's really hard, especially for those of us who are accustomed to doing assessments and initial assessments. It's really hard sometimes to ask an open-ended question. My favorite one that doesn't trip me up as much is tell me about. But you can ask why. Why do you want to quit? Why do you think your wife thinks it's important for you to quit? Why questions, how questions, what questions, those are always really good ones to use. Reflective listening. So a patient says, I don't want to quit, but my wife wants me to quit. I hear you saying you don't want to quit, but your wife wants you to quit. And the way to take that a little deeper with a person who's resistant is to say, why do you think your wife wants you to quit? And then the person has to think about it and hopefully tap into their own motivation. And you want to normalize conversations like we have many patients with tuberculosis who use tobacco who say the same kind of thing. I've heard this a lot. It's not really uncommon because this is the hardest thing you'll ever do in your life. Quitting tobacco is. You thought giving up cocaine or heroin was hard. This is going to be harder because nicotine is the most addictive substance on earth. And of course we want to support patients' autonomy and right to choose, but I would say don't do it first. Don't start with, well, that's your right. It is, obviously it is, and we can't do anything about that. Developing discrepancy is really key too. If you can get a patient talking about how they see themselves in the future and how they are today, they want to be recovered from their TB, they want to be tobacco free. So there's a bit of a discrepancy there, and most of us have that kind of discrepancy. You know, we may see ourselves in the future as a person who's going to go to the gym every day or run a marathon or something very simple, or enjoy retirement and sailing. But those visions we have of ourselves are often discordant with what we're doing right now. So we want to reinforce any kind of change talk that you hear, any at all. I know I need to quit. My wife needs me to quit, or my doctor told me to quit. Your doctor told you to quit. Why do you think that is? But if you find yourself arguing with the patient who says, everybody in my family smokes until they're in their 80s, and I just plain enjoy it. I quit everything else. It's the only thing I got left. If you find yourself arguing with that patient, stop right then, because they're only going to dig their heels in deeper, remembering what we said about people remember what they say. Boy, I told that nurse. I told her for sure I am not quitting. So we don't want people to walk away with that. Again, empathy. Empathy is key, and as I said, people know. And another little kind of technique is sometimes it's good just to ask permission, because people who are sick and who use tobacco, they've lost so much control in their lives. If you say something like, mind if we talk about your tobacco use for a minute? Hardly anybody will say no. And if they do say no, say, okay, well, we'll wait until next time, because I'm going to keep asking you. And we want to identify any successes that patients have had. There's the role with resistance, supporting self-efficacy. I believe these will be available for you, the slides from the webinar. So it's a little hard for me to read. We want to make sure that what we do is relevant, and this is not difficult for those of you who have patients with TB. Talk about the risks, short-term, long-term. Always better to get the patients to talk about them, the risks, the rewards. The patient rewards may be very different from the benefits of quitting. It may be something like, my daughter will let me hold the grandbaby if I don't smell like tobacco. Have them know what their roadblocks are, what's going to be the hardest part for you. And then for us as healthcare providers, every visit, every time. Don't stop doing it. Patients who recently quit, they are in danger of relapse. Use some of those same open-ended questions. How's the quit attempt going? What's the toughest thing you've encountered? And how did you do it? What do you think helped you the most? And always check in with medication. How are those patches working for you? Did you like the Chantix? Because we can try some other things. An interesting thing about patients who've quit is support. They need support, and they may have some depression, because withdrawal is real, both the physical and the psychological. Bad as the physical is, the psychological is worse. But one interesting thing about the drug called bupropion or Wellbutrin, they have found in the literature and the research that combining Wellbutrin with a patch sometimes really helps people with the depression. And down to the weight gain, Wellbutrin is also an appetite suppressant. So those are just things to think about and maybe educate yourself on. And we'll do a medication webinar in a few weeks. So intensive treatment is the same thing that we've been talking about. It's just 10 minutes and it's 4 sessions. It doesn't have to be the physician, the nurse, the respiratory therapist. It can be anyone who has a passion and an interest, and it can be different people from one session to another. But 4 sessions, 10 minutes or more. And ask the billing person in your office about billing for this. Medicare patients or patients with private insurance, you can bill for this. It's not a lot, but if you do it enough times, it can make a difference. And the individual, group, phone, they're all very worthwhile. Many of the quit lines in states now offer interesting tech kinds of solutions. They'll have a web coach, or they'll text patients, and a lot of people prefer texting or online kind of intervention to in-person groups and a telephone conversation. So intensive, if you can do it, it's the best. 10 minutes or more, and it involves all of the same strategies we've talked about. Assessment, even Interestingly enough, patients who are not willing to quit, they perceive that their healthcare providers are more interested in their well-being if they do that kind of intensive treatment with them. The counseling is practical and medications are key. The format doesn't matter, things that we've talked about. I think we're coming close to the end here. In the 2008 guidelines, what the panel of experts hoped that they would do is provide clinicians with enough information to motivate them to treat their patients with this chronic disease. And do remember, it's a chronic disease. To treat them consistently, effectively, and more importantly, I think to encourage a culture of healthcare in which failure to intervene with a tobacco user is not that different from failure to intervene with any other disease, and it's inconsistent with our current standards of care. So I hope perhaps this presentation may inspire you to intervene a bit more with the next TB patient that you see who uses tobacco. Thank you so much for your time and attention. I'm honored to have been able to present this to you.
Well, thank you, Kathy. That was a great overview of the different types of counseling tips and techniques to use with our patients. We have a few questions. Are you willing to take a couple of questions?
Absolutely. Thank you, Karen.
Sure. First off, from Betty, she asked, which drug has a better success rate for quitting?
In the latest research that I saw, it was a 26-week study, and they compared Chantix to nicotine replacement and counseling, and they both had a 30% or better success rate. There was not a significant difference between those two. Chantix does have a higher success rate than the bupropion.
Great, thank you. And Marjorie posed the question, how do you motivate people who say they really enjoy smoking?
That's a terrific question, and that is absolutely the hardest one. What I like to do for a patient who says they really enjoy smoking, I like to ask them, what do you think, enjoying tobacco as much as you do, what do you think would move you to even consider a quit attempt, to even think about it? What would it take? And sometimes people come back and they say, well, you know, I went to my doctor last week and I got a spot on my lung. Honestly, I hate that it has to go that far, but just ask people to think about that. What would it take? And there are people, I had a man tell me one time, actually a professional, if I relapse again, I'm taking it to my grave. So there are people like that, and I don't like to give up on anybody at all. What I tell respiratory therapists, though, busy respiratory therapists in the hospital who've got a long list of patients to see, if they see one patient who says, get out of my room, say, well, I'm going to drop this brochure here, and if you feel like taking it with you, please do, and then move on, because when you've got a long list of patients to see, you don't want to be spending a lot of your time. I mean, we think about return on investment here. When you have a long list of patients to see, you don't want to spend too much of your time on the most resistant when you can get those who are in much later stages of change and who are ready. It's a matter of where you put your attention. But I never give up on anybody.
Thanks, Kathy. We've got two more questions. Do you know what the cost difference is between smoking cessation products versus smoking cigarettes and cigars?
We have little tools that we give patients to figure that out with, but it really all depends on the price of the tobacco product. Now, I know that in a state like New York State that cigarettes are somewhere between $10 and $15 a pack, and here I believe they're $6 a pack. Pretty much the cessation medications are going to be between $40 and $50 wherever you go for a 2-week supply. The problem right now, and hopefully it'll be over soon with the deeming regulation, the problem right now is those darn little cigars, pardon my expression. But the cigars they can be $1 or $2 for a whole pack of Black & Milds and 305s, what my homeless patients tell me that they use. They're more toxic and they're more addictive. They have more nicotine, they have more poisons. But the FDA finally took all forms of tobacco, including cigar tobacco, under their umbrella. And my understanding is that by August of 2018, they'll all be regulated, including the electronic devices. They'll all be regulated, and the prices will go up. So if you smoke $14 Marlboros in New York, it's going to be a lot cheaper to use your nicotine replacement products. If in Florida or Kentucky or West Virginia you're paying $1 a pack for cigars, it might not be. It depends on how much you smoke. So I'm sorry I couldn't give you a definitive answer, but most tobacco control programs do have a little, like a card sort of thing that you can put in the number of cigarettes you smoke, put in the price, and you can come up with how much money you'll save a year by stopping smoking. And it's usually anywhere between $3,000 and $8,000 a year is what people save.
Well, that's helpful, Kathy. Thanks. There's one more question, and I'm not sure, Stephanie, if this will be handled in a future webinar, but if it's something you can answer quickly, we have a caller who wants to know how to handle withdrawal symptoms.
We'll cover that in the next webinar.
Well, then that might be a perfect segue to talk a little bit about the next couple of webinars that are coming up. Please go ahead and register for the next webinar that'll be held on July 11th, and that's the third in our series, which is on counseling skills and assessment for dependence. This webinar is going to focus on assessing levels of tobacco dependence, and will teach specific practical counseling skills and behavior modification strategies to utilize when treating patients with tobacco dependence. We also have another webinar that'll be on August 22nd, so mark your calendar for that one too, and we're going to discuss the pharmacotherapy options when treating tobacco dependence, how to use the products correctly, and ways to obtain the medication for your patients. And then our final webinar, so mark your calendar for September 5th, this one will focus on treating tobacco dependence among special populations, such as the homeless, people living with HIV and AIDS, and other groups. Our first webinar from May is archived, and that is accessible to you. So we hope if you missed the first webinar that you'll review that one. And this webinar today was recorded and will be archived as well. So please remember to complete your evaluation by close of business on Tuesday, June 13th. And thank you all for joining us today, and especially thank you to Kathy for the wonderful presentation. Take care, everyone.